Kanski lecture series, and we are going to start the age-related macular degeneration. So let's get started. Introduction. Age-related macular degeneration is a degenerative disorder affecting the macula. It is characterized by the presence of a specific clinical finding including drusen, RPE changes, and in the absence of another disorder. Later stages of the disease are associated with impairment of vision. So basically, macular degeneration is age related, and there is a macular changes due to age processing, and it is characterized by the presence of drusen, RPE changes, and there are absence of other disorder, and there is going to be the impairment of vision. So there are two types of AMD. It is a dry AMD and a wet AMD. So wet AMD generally means that there is going to be the blood vessel formation, whereas in dry AMD there is going to be the atrophy that is going to be present. Conventionally, AMD has been divided into two parts. Dry, non-exudative, non-neovascular AMD is the most common form, comprising around 90% of the diagnosed disease. Geographic atrophy is the advanced stage of the dry AMD. It has been suggested that the term dry AMD should be used only to describe geographical atrophy rather than the early stages of the AMD. So basically, dry AMD consists of the non-exudative or non-neovascular disease, and it is composed of 90% of the diagnosed disease. And geographic atrophy is the advanced form of the dry AMD. Then there is a wet AMD. Wet AMD is an exudative neovascular AMD, is much less common than dry, but is associated with more rapid progression to the advanced sight loss. The main clinical entities are CNV, so there is a choroidal neovascularization formation, there is going to be the pigment epithelial detachment, retinal angiomatous proliferation, which is RAP, and polypoidal choroidal vasculopathy, PCV. So all we are going to discuss in the coming topics. An expert consensus committee has provided a clinical classification of AMD. So let's see figure 14.2. So there is going to be the no category 1 is showing us a no apparent aging changes. It is consist of no drusens, no AMD pigmentary abnormalities. Normal aging changes, only droplets, no AMD pigmentary abnormalities. Then there is an early AMD, intermediate AMD, and late AMD. So the late AMD consists of the neovascular AMD or the geographic atrophy. The early AMD consists of the medium drusens, which is about 63 micrometer to but less than 125 micrometer, and there are no pigmentary abnormalities. In intermediate AMD, there are large drusens and any AMD pigmentary abnormality. So epidemiology. AMD is the most common cause of the irreversible visual loss in the industrialized countries. In the USA, it is responsible for the severe sight loss, better eye worse than 6 by 60. In about 50% of the white, 15% of the Hispanics, and 5% of the black with irreversible visual loss. So basically, AMD causes the irreversible visual loss, and it is responsible for the sight loss in USA, and in the 50% of whites, 15% of Hispanics, and 5% of the black. The prevalence increases with age, and the symptoms are rare in the patient under 50 years of age. So it is mostly age related, and it is present after the age of 50 years. In the UK, significant visual impairment, binocularly 6 by 18 or worse from AMD affect about 4% of the population age over 75 years. So in basically UK, the area, the vision almost 6 by 18 binocularly. AMD is affect about 4% of the population over the age of 75 years, 14% over the age of 90 years, and with 1.6% over the age of 75 having binocular acuity of less than 6 by 60. Patient with late AMD in one eye or even moderate visual loss due to non-advanced AMD in one eye have about a 50% chance of developing advanced AMD in fellow eye within 5 years. So if a patient is having a late AMD in one eye, he has a 5% chance of developing AMD, advanced AMD in the fellow eye in the next 5 years. And what are the risk factors for AMD? AMD is a multifactorial in etiology and is thought to involve a complex interaction between the polygenic, lifestyle, and environmental factors. Age is the major risk factor. So age is basically the most common risk factor. Late AMD is more common in white individuals than in other races. So white individuals have more late AMD. Hereditary family history is important. The risk of AMD is up to 3 times greater if a first degree relative has the disease. Variants in more than 50 genes have been implicated in AMD, including the two major susceptibility genes, the complement factor H, CFH 1q31, which helps to protect the cells from the complement mediated damage. Mutation increases 7 times when homozygous. And ARMS2 gene 10q26, which encodes a protein that is a component of the choroidal extracellular matrix, mutation increases 8 times when homozygous. So basically, first degree relatives, the risk of developing AMD is 3 times higher than other individuals. And also there are certain kinds of gene, two of which are most important. If one is the CHF gene, and basically if this mutation is present in and homozygous mutation is present, then the risk increases up to 7 times. And the CFH is basically help protecting the cells from the complement mediated damage. And then there is an ARMS2 gene, which also when homozygous mutation, it can cause 8 time risk of developing um, AMD. And it is basically the component of the choroidal extracellular matrix protein. And genes related to lipid metabolism are also thought to be important. There is no advantage in undertaking genetic testing while studies confirm the value of such testing for determining prognosis or for the response of treatment. Smoking roughly doubles the risk of AMD. Hypertension and other cardiovascular risk factors are likely to be associated. Dietary factors, high fat intake, and obesity may promote AMD, with high antioxidant intake having a protective effect in some groups. So, smoking can also cause AMD, hypertension can also cause AMD, dietary factors, high fat intake can cause AMD. Aspirin may increase the risk of a neovascular AMD, though the evidence is limited. If an individual at high risk requires an antiplatelet agent, it may be sensible to consider an alternative to aspirin. Other factors such as cataract surgery, blue iris color, high sunlight exposure, female gender are suspected, but their influence remains less certain. Then there is a drusens. Drusens are histopathologic. Drusens, singular drusae, are extracellular deposits located at the interface between the RPE and the Bruch's membrane. So you know that below RPE is a Bruch membrane, and the drusens lie between them usually. They are composed of a broad range of constituents derived from the immune mediated and metabolic processes in the RPE. The precise role in the pathogenesis of AMD is unclear, but is positively associated with size of lesion and the presence or absence of associated pigmentary abnormalities. So basically, they can be due to the immune mediated or metabolic products from in the RPE. Age-related drusens are rare prior to the age of 40 but are common by the 6th decade. The distribution is highly variable and they may be confined to fovea, may encircle it or form a band around the macular periphery. They also may be seen in the peripheral and mid-peripheral fundus. So they can be located anywhere. They can be present at the fovea. They can encircle around the fovea. They can be present in the macular periphery as well. So, what are the clinical features of the drusens? There is a strong association between the size of the drusen and the risk of developing late AMD over the 5-year period. So, there are small drusens which are known as druplets, intermediate drusens, large drusens, and there can be dystrophic calcification and pigmentary abnormalities. So, small drusens or druplets, sometimes termed as a heart drusens, are typically well defined, white, yellow, and by definition measure less than 63 micrometer, less than half of the width of the retinal vein at the optic disc margin in diameter. Their presence at the as the only finding probably carries a little risk of visual loss unless associated with pigmentary abnormalities. So basically, droplets is if the it is small droplets or small drusen are having a yellowish white lesion which is about the size of a 60 less than 63 micrometer, which is about the half of the retinal vein which is present at the optic disc. And intermediate drusen is between the 63 to but less than 125, whereas the large drusen is greater than 125 micrometer in diameter in size. Intermediate drusens are fairly well-defined yellow-white foci deposit at the level of RPE measure between the 63 micrometer and 125 micrometer. So it is between the small and the large drusen without accompanying pigmentary abnormalities. They only carries a small risk of progression to late AMD. Late AMD over 5 years, but this increases to over 10% if pigmentary abnormalities are present in both eyes. So if there is a pigmentary abnormalities, then there are 10% risk of developing advanced AMD in a case of a intermediate drusens. Then large drusens are a less well delineated yellow-white deep retinal lesion measuring over 125 micrometer in diameter. The term soft drusens is sometimes used synonymously. As they enlarge and become more numerous, they make paralysis, giving a localized elevation of RPE, a drusenoid RPE detachment. The presence of large drusen in both eyes is associated with 13% risk of progression to late AMD over 5 years, but with accompanying pigmentary abnormalities, this rises to about 50%. So large drusens is also known as soft drusens, which is about greater than 125 micrometer in diameter. And if there are so many, they can cause the elevation of the RPE, which is known as a drusenoid pigment epithelial detachment. And if there are no pigmentary abnormality, risk of progression to late AMD is 13% over 5 years, whereas if there is pigmentary abnormalities, then the risk increases to 50%. Dystrophic falsification may develop in all types of drusens. Pigmentary abnormalities, hyper and hypopigmentation, not due to other retinal diseases associated with significantly higher likelihood of progression to late AMD with visual loss. Tip: there is a strong association between the risk of developing advanced AMD, drusen size, and macular pigmentary changes. So, pigmentary abnormalities can be hyper and hypopigmentation. So let's see figure 14.29. It is showing drusens, a histopathology showing high homogeneous eosinophilic deposits lying between the retinal pigment epithelium and the inner collagenous layer of the Bruch membrane. So you can see this, the material, the deposits can be seen. P is showing OCT showing drusens. So this is an arrow just beneath the RPE. You can see that there is a lesion. So C is showing us an initial image, P is showing us the same eye 4 years later. So you can see the lots of drusens, increase in number and size of drusens. E is showing us the drusens with associated pigmentary abnormalities, and F is showing red-free image of the E. Next is the OCT. Medium size and large drusens are seen as a hyper-reflective irregular nodules beneath the RPE located on or within the Bruch membrane. So drusens are seen as a hyper-reflective not irregular nodules between the RPE. Fluorescein angiography FA findings depend on the state of the overlying RPE and on the affinity of the drusens for fluorescein. Hyperfluorescence can be caused by the window defect due to atrophy of the overlying RPE or by late staining. Hypofluorescent drusen masking background fluorescence are hydrophobic with high lipid content and tend not to be stained. So drusens on FA can be hyper reflective, hyperfluorescence, and the hypofluorescence. Hyperfluorescence can be due to that if there is an RPE atrophy or there is some kind of late staining, and hypofluorescent will be because of the very high lipid content in the drusens that is blocking the background fluorescence. Then, what are the differential diagnosis of the drusens? A number of conditions features lesions similar to age-related drusens. At least some may have a similar pathophysiological basis. So, Doyne honeycomb retinal dystrophy, cuticular drusen, type 2 membranoproliferative glomerulonephritis. So these are all some differential diagnoses. So this is a retinal dystrophy, Duane honeycomb retinal dystrophy. Malatia levantinis autosomal dominant radial drusen is an uncommon condition in which fairly characteristic drusens appear during the second or third decade. So usually, in a case of a Duane honeycomb retinal dystrophy, there will be the characteristic drusens present during the second or third decade. Cuticular drusen, also known as grouped early adult onset or basal lamellar drusen, not to be confused with basal lamellar deposit and basal linear deposit in AMD. See dry AMD below, tend to be seen in relatively young adults. The lesion consists of a small 25 to 75 micrometer yellowish nodules that tend to cluster and increase in number with time and can progress to serous PED. FA characteristically gives a star in the sky appearance. The condition has been linked to a variant of a CFH gene. Basically, the cuticular drusen is also known as a basal laminar drusens, which is different from the linear deposits in the AMD, and they are consisting of a very small yellowish lesion, which can lead to serious PET as well. And they give on the FA, they give characteristic starry in the sky appearance, and this is a variant of a CFH gene. Then there is a type 2 membranoproliferative glomerulonephritis is a chronic renal disease that occur in older children and adults. A minority of the patient develop bilateral diffuse drusens-like lesion. The CFH gene has again been implicated. So this is a Duane honeycomb retinal dystrophy A. B is showing us a cuticular drusen. C is showing FA, showing hyperfluorescent spot stars in the sky appearance. Then there is an antioxidant supplementation, which is basically sometimes the treatment we advise for the cases of AMD, but there are different studies that meant to give these antioxidant supplements. Introduction: there is a substantial evidence, notably from the age-related eye disease AREDS, known as AREDS 1 and the following AREDS 2 study, that taking high dose antioxidant vitamins and minerals on regular basis can decrease the risk of development of advanced AMD in individual with the certain dry AMD features. So basically there are studies that has been conducted that there are certain multivitamins that we use in a case of AMD, it can lead to the decrease in the progression of the advanced AMD in certain AMDs. The recommendation was made in AREDS 1 that individual age over 55 should undergo examination for the following high risk characteristic. If one or more are present, should consider antioxidant supplements. So there are four indications. Number one is if there is an extensive intermediate drusens, one or more large drusens. So if there are extensive intermediate drusens, which is about 63 to 125 micrometer drusen, one or even large drusen 125 micrometer, if there is a geographic atrophy in one or both eye, if there is a late AMD in one eye. Greatest benefit in AREDS 1 is when there is late AMD in one eye. AREDS 1 study, the reduction in risk of progression to advanced AMD at 10 years was in the order of 25 to 30% for those with the more advanced of these and at baseline who took supplements. However, supplements did not discernibly reduce the progression in those with early or no AMD at baseline. So, if the patient have no AMD or early AMD at baseline, these multivitamin will have no benefit. But there studies show that 10 years there is a reduction in progression of about 25 to 35%. Then there is an AREDS 2 study. This regime used in AREDS 1 consists of the vitamin C, vitamin E, beta carotene form of vitamin A, 80 milligram daily of zinc with copper to prevent zinc-induced anemia. So basically, the AREDS 1 study have the was given multivitamins, which was consist of vitamin C, vitamin E, vitamin beta carotene, which is of vitamin A, and 80 milligram of zinc with copper to produce the zinc induced anemia. So these were used, but there was certain hazards associated with it. However, high zinc doses are potentially associated with genitourinary tract problem, and there are data suggesting that 25 milligram of zinc may be the maximum level that is absorbed. Beta carotene increases the risk of incidence of lung cancer in current and former smokers. It 2 looked at adjusting the beta carotene and the zinc component, and also whether additional or alternative supplements should enhance outcome. ARIDS 2 find. So basically, ARIDS 2 represent, because the beta carotene was associated with lung cancer, so it was replaced with lutein and zeaxanthin, whereas the zinc dose was decreased to almost 25 milligram. The carotenoid, lutein and zeaxanthin are a safe alternative to beta carotene and probably superior, because possible 18% reduction in the risk of advanced AMD above that conferred by the ARIDS 1 regime. Lutein and zeaxanthin supplementation added to the original ARIDS 1 regime was only associated with the statistically significantly reduced 25.6% risk of AMD in patients in whom the dietary intake of these was not already high, self-described, and blood testing. So you can the lutein and zeaxanthin supplementation was used in the ARIDS 1 regime, and it shows that there are 25.6% reduction in the AMD in those patients whose dietary intake was not enough. There was evidence that competition for absorption between different carotenoids may have prevented the demonstration of superiority in other patients. The group also showed a one-third reduction in the likelihood of cataract surgery. Adding omega-3 fatty acid to the regime did not seem to enhance outcomes, so it was not added omega-3 fatty acid. Lowering the zinc dose did not lead to a statistically significant prognostic worsening. So if you lower the dose, it does not have any worse effect and is likely to be associated with worse incidence of side effects such as gastrointestinal and urinary problems. So recommended daily supplementation on ARIDS 2 was that vitamin E was given, which was about 400 unit international unit. Vitamin C, which was given 500 milligram. Then there was a lutein, which is about 10 milligram, zeaxanthin 2 milligram, and zinc 25 to 80 milligram. The lower dose may be equally affected. Copper 2 milligram, which may not be required with the lower zinc dose. Other consideration: a green leafy vegetable intake. Confers a lower risk of AMD, and for individuals with strong family history of AMD and those with early AMD who do not meet the ARIDS criteria, this may be a proven lifestyle choice. So you can ask the patient to have a green leafy vegetable. Cessation of smoking should be advised. Protective measure against the exposure to excessive sunlight should be considered. Some authorities consider that evidence still support the regular consumption of the oily fish. So that's it for the part 5. See you in the next lecture.